Hi and welcome to the section on metastatic spinal cord compression, or MSCC. In this lecture, we'll be discussing the early warning system. That would be an ideal help for all clinicians. We'll be discussing some red flags and some prevalence and incidence rates of metastatic spinal cord compression. So you will see that metastatic spinal cord compression, or MSCC, is a well-recognized complication of cancer. Clinicians could be assisted, and we agree with the research findings here, that an introduction of an early alert system for MSCC would be of extreme help. Now, if we go back to the red flag section that you read through and listened to earlier, as long as your questioning your case history is good and in depth, we're hoping that a lot of those questions that we potentially gave you would cover some of this. In essence, if somebody's had a history of cancer, especially if you cannot understand why they have suddenly developed pain with back pain, then that would be a red flag, essentially, because there is no causative factor, but they have a history of cancer, and it's extremely relevant to get them to a medical diagnosis as quickly as possible. Metastases to the spine occur in about 3 to 5% of patients. Now, this is within the first 5 years, and main causes from secondary metastases are the primary cancers of the lung, prostate, and breast, where the incidence rate is about 1/5 of those sufferers, about 19%. Now, once the patient develops those symptoms, they generally take around 3 weeks to present with those symptoms, and those symptoms can continuously develop over a period of 3 months. That's what we mean by that potentially is reporting to you and then going on to seeing an oncologist specialist or whoever the consulting doctor deems appropriate. Generally, though, by the time of presentation, about 48 of those patients are unable to walk due to pain and discomfort. So it would be a good idea to have a structured, early identifying red flag system, because this affects about 4,000 cases, 4,000 people in the UK per year. Every day of delay potentially leads to an onset of paraplegia. In about 85% of paraplegia cases, it's due to vertebral collapse. So it's a secondary metastasis causing the vertebral collapse. And if we can have a good structured system across all therapies, we would see that this would hopefully be limited. A sudden onset of MSCC has a worse functioning prognosis than on a gradual onset. So what we mean by this is the faster the symptoms come on, the worse potentially the prognosis. So this always comes back to, and you'll hear me repeat, an early identification system. The downside is, in early stages of disease, the commonly known red flags of what we deem for cancer may not be there. And this is very common, such as weight loss, constant pain, night sweating, responding to an intervention for a short time. They can attribute certain activities or certain incidents, such as a traffic incident, relating to their cause. That essentially, these may not be there. So it can become very, very difficult. Also, we need to take into account that many people every day walk around with asymptomatic and undiagnosed cancers. And again, this is around 25% of metastatic spinal cord compression cases. So there's quite a lot of people, unfortunately, walking around like this. So it's important, again, when we go back to those questionings, it's important to listen to the patient, any limb weakness, and you're always looking for these things, which are difficult to detect, and we appreciate that they're difficult to detect, and even the presence of subjective reports. However, we need to be aware that the sensory level is not necessarily an indication of metastatic spinal cord compression. We would ideally need to look at the whole spine. So what this means is, if you suspect that a patient has a secondary, or there may be an undiagnosed space occupying lesion, as we call it, a cancer, they need to be referred immediately. Now, you should be asking yourself the question, well, if it's not there, they're not diagnosed, how do I know? You won't at this stage, but what you will know is that the symptoms that they are describing, leading to some of the clinical tests, or potentially you have treated the patient with no significant improvement, there is the red flag. A good function of bladder and bowel doesn't always take out the risk that the cord has a dysfunction. This can happen generally to the later stage of MSCC. So again, even though we've given you some questions and you ask about bowel and bladder, they may say it's normal to always keep your eyes open and ask good questions, because overall the history is the key. So back to red flags, more so now directed at MSCC. The following red flags, 3 red flags, identified to be well known. Band-like trunk pain. So this is a band around the waist. Vague and non-specific lower limb symptoms and decreased mobility. But again, even those red flags are vague. It's got to hit and coincide with the history. About 94% of patients complained of back pain as their first symptom of MSCC. There is an appreciation to around 8 other red flags, which include the 3 we've already spoken about. Referred or band-like pain, escalating pain, poor response to treatment, which we just spoke about. Different character or site of pain than the previous, so it's moving around. A funny or odd sensation or heavy legs that they've never had before. Lying flat always increases pain. We seem to see for most people lying flat tends to ease. If it's not, that could be a red flag. Agonizing sort of severe back pain, any pain that you cannot alleviate, i.e. not just from treatment, but in moving in any position. If you cannot alleviate the pain, that's a red flag. Gait disturbance, unsteadiness, stairs are difficult. These could be MSCC, but they could also be potentially motor neuron problems. So again, that in itself on its own may not be a red flag, but to us as manual therapists, I would say that is a red flag until you have further information. And sleep disturbance with night pain. But again, generally that is again vague, because if you are in pain, sleeping can be difficult. But again, this is over potentially a period of time. So have an appreciation for these red flags and see if they fit the history of what your patient is coming in with. Now, the late signs of MSCC are motor deficit, sensory deficit, and bowel and bladder disturbances. These, again, you still need to be asking these questions, because what does that mean by late? Depends on how quickly they progress. Overall, once they progress to these signs and symptoms, the functional outcome is poor, unfortunately, as well as survival. So this is why the same questions of bowel and bladder, motory deficits or motor output, sensory output, need to be asked every single time. And the same can be reiterated by an assessment, as we've said, shared by GAIN. And we suggest that you either locate, download the guidelines from GAIN, which are the Guidelines and Audit Implementation Network. And they list their 4 key signs of MSCC as pain, sensory dysfunction, motor dysfunction, bowel and bladder. But again, we need to read around these. It's very important to do so. So that brings us to the end of the MSCC, or metastatic spinal cord compression. In conclusion, an early warning signal sign should be agreed, so that all practitioners are saying the same thing. But we suggest going back to the previous lecture in this series to discuss those questions, read through them, see if you can integrate them. And as I said earlier, you should be asking those questions every time. And any form of suggestion of a red flag, you should be analyzing it and referring where appropriate. You're now free to move to